For me, I'm a family practice guy. I've done a whole bunch of different things, executive medicine, aviation medicine, high altitude medicine, acute and emergency medicine. But you know what I do for family medicine? When I'm looking at hypertension stuff, I usually give everybody carbs. Personal preference, sometimes a combination with hydrochlorothiazide, but you gotta try to make your life easier, okay? But it is very dependent, so make sure that you're looking at your patient before you pick your medication. All right, so we stopped yesterday at pneumonic plague, right? So we stopped? Yes, no, maybe?
Yes.
Yes?
I have the slides in there. There we go.
We stopped at bubonic plague?
Yep. You might have actually,
You're on a map.
29.
If I talk too much, let me know, okay? All right, so bubonic plague, most common form, right? What happens, a flea bites you, a flea has already bitten an infected rodent of some sort. It gets into their saliva, when it bites you, it gets into your muscle, it propagates, and then your body's trying to get rid of it, so it goes generally to the nearest area, which would be your lymph nodes. Most flea bites usually occur in your lower extremities, right? The most common, usually the genital area for your lymph nodes will be the ones that are swollen. So as we talk, the bubonic plague itself will have buboes. Buboes are those swollen, tender, red, enlarged lymph nodes because they're catching that infection. All right. So if you see that, one of those things that you really need to think about would be bubonic plague. Okay, and then you'll have malaise, high fever, headaches, cough. Right, but there it'll tell you if you want to highlight something. Tender swollen lymph nodes, which is what we call buboes, will be a hallmark for bubonic plague. All right. And there, the last statement there tells you usually your lower legs are usually the ones that are bit most frequently. Okay. Next, you have your septicemia. Okay. This is also a reason why we call this thing the Black Death. Septicemia is what causes that disseminated intravascular coagulopathy, the fragmentation of the fibrins within your clotting factors that block up those small vessels, right? You guys remember the small vessels we talked about yesterday? Right? Okay, so those are all the areas that are gonna turn black on you because of this. Okay? But as you can see, this one has no buboes. All right? So what happens? Usually, when the flea bites you, it'll bite you in an area where it goes directly into your bloodstream. Okay? It completely bypasses the muscle layers where it continues to propagate, and then your body tries to make it go away, and it takes it to the lymph nodes. So there's no buboes when we talk septicemia because it's just running in your bloodstream. All right? And there it tells you you get gangrene of your extremities, skin, tissue necrosis. Then you get all these other symptoms, high fever, CNS, shock, skin changes. Now, if you let bubonic plague and you let the septicemia go without treatment, you end up with pneumonic plague. Or the more common way to get pneumonic plague is by somebody else who has pneumonic plague. Or you're in contact with an animal that has pneumonic plague, because this is respiratory. This is the main way that most people get pneumonic plague back when we had those 3 large outbreaks in the world where it spread really, really bad, is because of the pneumonic plague. When somebody gets this, all they need to do is cough, yell, scream, talk. As the stuff comes out, you breathe it in, now you got it, all right? What happens with these guys? So unlike anthrax, where you have lethal and edema toxins, the plague has a protein that it releases to the macrophages. and the neutrophils, right? Those things go and try to kill the plague. But they release this protein that keeps it from getting killed. And then it causes this giant inflammatory reaction inside your lungs. Everything swells up, everything starts leaking, and nothing's working anymore. That's literally what happens inside your lungs when the plague gets in there, okay? And that leads you to all these symptoms here, okay? Once you have that extra inflammatory process going on, once you start having lung tissue destroyed, you end up having that hemoptysis, right? That's fluid inside your lungs and you start spitting up blood. It's almost like tuberculosis, okay? But a different process. You start coughing because your coughing reflex is affected. You have chest pain, not breathing right, okay? Backs up towards your heart. Your heart starts pumping faster because it's trying to get more oxygen through your system, but it's not working because you got fluid in your lungs. Right? So you end up with a lot of this kind of stuff. That toxic appearance is basically because you're not breathing anymore. That oxygen, carbon dioxide exchange is really not working. Okay? So that's why you end up with a whole bunch of these symptoms. But pneumonic plague itself, worst one of all of them, and generally respiratory. Okay? Okay, this is a little kid you can see down here. Where he's got an ulcerated flea bite. This is what a bubo looks like. It's not an extremely clear picture. But you look at this posterior cervical lymph node here. It's swollen and enlarged. Very tender. Okay, very tender. Most of the times you will see that more so in an inguinal area, but it's really dependent on where the flea bites you. Okay? So usually the closest lymph node is usually what gets infected. Alright, so what are you going to look at? White blood cell count, 200,000. Extremely important, if you do have pneumonic plague, make sure you do a chest x-ray. Okay, extremely important. So that fibrin degradation test, that one's going to show you that your clotting factors are being destroyed and you're getting all this fibrin split product. That fibrin split product is what usually gets caught up in those small vessels, which causes a lot of that necrosis. Okay? Your LFTs are gonna go up, right? It's causing some hepatic damage there. So 3 things to look at. So this right here, safety pinning staining, right? If you choose to stain it, this is very distinctive. If you look at them, they almost look like safety pins. So if you see safety pin staining, that's kind of a hallmark sign in a stem of a question that really tells you, hey, this is probably the plague. All right. But the gold standard here is culture. Okay. 18 to 48 hours with a confirmation of 48 to 72 hours. Now, I will tell you, if you think it's septicemia, or excuse me, if you think it's pneumonic, you need to treat right away. Pneumonic plague, those people will die within 24 to 72 hours after the symptoms kick in. So you should not wait for your results. This is where we come and tell you, you treat the patient, not the illness. Okay? 24 to 72 hours is usually the amount of time that those guys usually last after all those respiratory issues begin. Okay? So don't wait for this stuff. You have a little bit more time with bubonic or septicemic plague, but understand, same deal with septicemia. Septicemia is a little bit longer, but septicemia will lead you to organ failure and organ damage. So the sooner you can get meds on board, the better off your patient will be, and you will have better outcomes for your patients. All right? So you don't necessarily have to wait for this stuff. As you can see, confirmation Your culture, which is the gold standard, takes some time. All right. You can do serology, IFA, or ELISA. That'll look for your IgGs and IgMs. Okay, and then there it tells you PCR. It detects DNA, but it's expensive and not always available. All right. A lot of times where this occurs, right, Africa, you don't usually have PCR available. So sometimes you have to use other means. Culture is usually available in a lot of places, as is serology, IFA, or ELISA. Yes, sir.
Sir, when they're dying within like 24 to 72 hours post symptom onset, but the symptoms are like headache, tachycardia, chest pain, are you just going off of patient history to make that determination of, okay, I'm gonna start treating for plague? But like they're gonna die that quickly without labs, like what's gonna be your kind of your tipping point, like I'm gonna start treatment for plague versus I'm gonna start investigating further into what type of illness this is?
Okay, everybody hear that? Okay, how do we figure out that we need to start treating a patient? Right? And you mentioned it yourself. Key point would be your HPI. Okay? Key point would be your HPI, along with your symptoms, along with the location of where he's been. If he tells you he just came back from Madagascar, hey, probably should think the plague, right? Versus, hey, I just came from Long Island, right? Long Island. Probably not the plague, right? So HPI is where you go back to HPI in infectious disease is extremely important, right? As is location of where you were. When you're doing your HPI, you ask those questions, right? And this is where ID is a little bit different than a lot of the other things that we're gonna talk about, because location and mode of transmission are extremely important for signs and symptoms of what you think this thing could possibly be. Now, in the scenarios that we'll usually give you, whether it be ours or the PANTS, they'll give you a lot of this stuff. They'll give you a mode of transmission, they'll give you a location, they'll give you a time, and they'll give you a bunch of symptoms. Okay? And that's generally how I write mine. Okay? So you'll get a bunch of these. So as we go through these, you can look at where the most common locations are, what the common symptoms are. In these cases, especially if we're talking about bubo specifically, bubonic plague specifically, I'll probably give you signs and symptoms of a bubo. I probably will not say, hey, he has a bubo. I will probably tell you, hey, they have a swollen, inflamed, tender lymph node, with an expectation that you know what that means. All right? That's usually how I write my questions. All right?
Sir,
Yes, sir.
you said pneumonic is sequelae to septic and the pneumonic plague.
Yes, sir. So, two ways that you can get pneumonic plague. One, you breathe it in from something that's infected, either another person or an animal. Two, if you let bubonic and septicemic run its course, it'll eventually get your lungs and it'll eventually cause you pneumonic plague.
Yeah, so will the buboes go away and then you get pneumonic, or?
At that point, so the buboes are only because your body's trying to get rid of it initially. Okay? So, if your body can take care of it, regardless of whether you end up with pneumonic plague or not, you may still have the bubo. If your body is able to handle it and take care of it, the bubo may go away on its own. But you'll still end up with pneumonic plague.
Yeah,
Does that answer the question?
Yeah, I just wanna clarify, cause it says no buboes present pneumonic, but you can't possibly have buboes with pneumonic, it's a sequelae.
If it's a sequelae, yes. But generally, if you're looking straightforward as, hey, I get it as a respiratory issue, no, you're not gonna have it. Everybody understand that concept? No? All right. Anything else? All right. Kind of easy. Here's your treatment. Okay. So if we're talking bubonic, it's either doxy or cipro, one or the other, not both. Okay. Drug of choice for septicemic or pneumonic will be streptomycin or gentamicin. Okay, one or the other. So for the part at the bottom where it says post-exposure prophylaxis, you can see the first bullet, it actually says prophylaxis for close contacts. So this is very similar to the COVID stuff. If you have been a close contact for more so a pneumonic plague patient, then you would be put on either doxy or Cipro for 7 days. And that's just to make sure that you don't get it as a close contact. Okay? Back in the 1940s, we used to have a vaccine here in the US, but that has since gone away. There was a lot of issues that they had with the vaccine itself, particularly its efficacy and the amount of time that it actually lasted. So we no longer have a plague vaccine in the US that we actually use. There's a whole bunch of differentials, right? Some people ask you, hey, what kind of other respiratory possibilities this could be? There's a whole bunch of choices. Smallpox. Alright, so smallpox is one of those that we can actually say that public health and who is the World Health Organization. So whenever I say who, I'm referring to the World Health Organization, have done great work with eradicating a disease problem. Smallpox is one of them. In 1980, the World Health Organization actually declared smallpox eradicated. Right? Every once in a while in the hills of Afghanistan, we still get some wild smallpox pop up here and there, but mostly worldwide, not really an issue too much anymore because of the international vaccination programs that they have for this. Okay. Here in the US, around the early 1970s or so, we actually stopped giving out smallpox vaccines to kids. So if you're old enough, you may have a little scar on your arm if it wasn't caused by the Army giving you some smallpox vaccines. All right. But it is airborne via respiratory droplets. The offending organism is variola virus. Okay. Direct contact, close proximity, sometimes contaminated objects. If the fluid from the pustule that develops gets on stuff and you touch it, you may get it. Okay? So this is technically only a human type disease, so you don't usually see it in other animals. There it gives you a high-risk population. Obviously the unvaccinated, right? But the people that you really need to think about are the children, okay, young kids, the elderly, and the immunodeficient. Those three categories are always in most of these disease processes that we're going to talk about throughout this ID course for a high-risk population. Okay. It is worldwide. It is worldwide. Okay. Infectivity-wise, it takes less than 100 virons. Okay, virons is a cell of the infection to actually cause you smallpox. Less than 100 virons is less than a drop that'll fit on the head of a pin. Okay, so this is pretty infectious. Here it tells you natural immunity may give you lifelong immunity. And then right now as it stands, for the vaccination part, you may get 10 to 15 years protection from the vaccine that we give you. All right. Okay. No natural sources remain. according to the World Health Organization. They've been using smallpox as a bioweapon for a long time. Here's some historical facts: French Indian Wars, right, when they gave them the blankets. Their smallpox discontinued in the United States around 1972. We did continue to go beyond that because we were using up some of our stores. So some kids beyond 1972 still get the smallpox vaccine. Okay, the last natural smallpox occurred in Somalia in 1977, and in 1980, the World Health Organization declared this pretty much done. All right. Just remember that we still have stockpiles of this stuff, so it's still a possibility that we can use this as a bioweapon. This was a thought process when we were in Afghanistan for a while, which is one of the reasons why we actually started giving soldiers smallpox vaccination again. All right. So there's really one type of smallpox, but it has two different forms. It's got the variola major and the variola minor. Most classic cases that you see are usually the classic smallpox, which is the variola major. You have two subcategories. You have hemorrhagic smallpox and malignant smallpox. We'll talk a little bit about those, but both of those are basically fatal. All right. Okay, and a 12-day incubation period, okay, followed by 2-day prodrome. So you're gonna get some symptoms before the stuff actually kicks in. All right, there's your symptoms right there: fever, headache, backache, malaise. And then after the prodrome kicks in, you're gonna end up with some macular papular lesions. All right. Now, some of these lesions look like chickenpox, right? Smallpox, chickenpox. The main way to differentiate them, because usually we look at this and we clinically diagnose smallpox. I don't have to send stuff off to the lab. Can I? I can. Do we generally? No, we generally do. Okay. But to differentiate smallpox from chickenpox, just take a look at what's popped up, right? So if I look at the arm, all the pustules on the arm should be about the same stage. They should all look like they popped up around the same time frame. Versus looking at a chickenpox, where you still look at the arm, but you have one that looks like it's about to rupture, one that's already ruptured, you got another little one that's about to pop up. So the stages of the pustules are in different stages of growth. That's generally how you differentiate smallpox and chickenpox, by just looking at it. All right. So there at the bottom it tells you are all at the same stage of development on a given body part. So when you're looking at smallpox, they should all look the same if you're looking at the arm. They should all look the same if you're looking at the face. Okay. So initially it's going to be oropharynx, right, because it's respiratory, face and arms. So smallpox usually on the face, arms, and legs. Smallpox usually on the face, arms, and legs. Chickenpox somewhat on the face and the trunk, most commonly. Do they spread to the arms? Yes. The smallpox spread to the torso? Yes. But the congruence of the pustules will be mostly on the face and the arms for smallpox. All right. And there it tells you spreads to trunk and legs, does not spare the palms and soles. Another way to differentiate some of these disease processes is whether it spares the palms and the soles of your feet. Okay? Some of these do, some of these don't. So this is a way to differentiate. Smallpox does not spare the palms and soles, so you'll get blisters on your palms and on the feet. Usually with chickenpox, you may not get the blisters on the palms and soles of the feet. Do they occasionally happen? Yes, especially with immunodeficient patients or immunocompromised patients. You'll get slightly different atypical presentations because their immune system's not working as well, right? Okay, so here's your life cycle of your macular papular lesions. Vesicle or oral lesions, usually 1 to 2 days, round, tense, and embedded pustules. So sometimes some of them will have like little, like they've been poked right in the middle. You'll see like, it's got like a little dot in the middle of them. Not all the time, but you'll see them when we pull this thing up. Then they crust and scab over by about 1 to 2 weeks later. And then these things usually may leave you scars, all right? Usually this thing lasts anywhere, depending upon your immune system, it could be as short as 14 days, it could be as long as 28, okay? So you got a 2-week range there for getting better. All right, here's your day 0, day 3, 7, 10, 14, it starts to ulcerate and scab up. All right, it looks a little bit better when you look at it on a baby, right? And we said initial, usually face and arms, right? So let's look at this baby. This is A4, the little rash of the pustules, and you can see them popping up here, right? You can see that it's really broken out much on his face, but if you look at his torso, he doesn't have much on his torso, right? So if you look at day 6, okay, look at the face, okay? A lot more on the face, not a lot on the torso, but then look at the arms. Okay, he's got a lot of the arms. So when I mentioned these things have like little dots in the middle, so this one is very prominent where you can look at the little center portions of those pustules or vesicles and see that it's got little divot in it. Okay, so that's day 6. Here's day 8. Look at that, right? You can see a lot more has already gone onto his arms and onto his face. Okay? And then here's the scab portion. And as you can see down here at the bottom, right, over his torso, you don't see tons on the torso, right? You don't see tons on the torso compared to the face. Alright, so face and arms, usually a lot more. I put this guy on here, right, because you can take a look at his face, man, right? He's got a lot on his face, he's got a lot on his arms compared to his chest. Right? But what I want you to look at is, it's like grass and dirt to you. Right? I'd like you to understand that when you work in other countries and other places, and a lot of times where this is more prominent, they don't have the medical care, the medical system, the medical support, the medical setup that we have here, all right? So some of the things that we talk about are, hey, if you find yourself over there working on some stuff like this, you have some other options, right? Other than just saying PCR, right? And I use the example of being far forward in Nangalam in Afghanistan. We were working with a host nation clinic, right? We were helping them, they were helping us, they were giving us some info, right? One day we went to the clinic, doctor was gone, missing. Nobody knew where he was, right? One of his family members came down and was like, hey, Taliban took him hostage. And there was nobody in the clinic. I had been working with him in the clinic, so I ran his clinic for a week. Right? I learned a bunch of stuff from him. We got him medicine from the NGOs, we got him medicine from MedReadies. And then a week later, he came back all beat the fuck up. Like, hey, I escaped. Let's go see some more patients. I was like, oh, great. Here's your clinic, right? But I learned a lot from him, but I couldn't use a lot of the things that I knew from here because they don't have a lot of the stuff that we have here to do this kind of work, okay? So understand that when you're working over there, you don't have all the support that you actually have here. So sometimes you need to know a little bit more or be able to understand what they have capability-wise there to be able to take care of their patients, okay? Here's another little kid. on the floor in a house. And I would assume that to the right would be his mother or his grandmother, right? Because we have to also have a cultural understanding of what happens over there. That cultural understanding is that it is a multi-generational family that usually lives in these homes, right? And they help each other out, right? So this kid was probably oozing from all those scabs that you see there if the parent was not educated enough to understand that that fluid can cause them to get it, then they may get it if they have not already been vaccinated for it. Alright? So just understand the culture and the support that they have over there versus what we have here, especially if you find yourself working over there. Alright? Okay, so here we're going to mention hemorrhagic smallpox. This looks a little bit dusky. Okay? Instead of those vesicles and pustules that pop up, you get petechiae. Okay? Petechiae is just little red spots that you're going to get. Why? Because your vessels are leaking and bleeding. That's why you get petechiae with hemorrhagic smallpox. Right? A lot of times, as it continues on, it may coalesce, but what ends up happening is you end up having multi-organ failure. Okay? Organs inside stop working, right? Because they're leaking everywhere. So hemorrhagic smallpox, almost 100% mortality rate. That's what it is. We don't have any antivirals, we don't have anything that we can do. Saving grace for this is that both hemorrhagic and malignant smallpox are a very, very small, less than 1% of smallpox cases. Alright? So the malignant smallpox is even a lot different than standard smallpox or the hemorrhagic because the presentation for this one, although it's a much longer incubation period, it's a softened, flattened, velvety little vesicle. And it's red. It's reddish or brownish. Okay? So the presentation is completely different. Alright? But regardless, we have nothing for it. Alright, so both of these, just about 100% fatality rate. Alright? This is what hemorrhagic smallpox looks like. So these are all petechiae. So over time, these things can confluence, and what happens is they just become really big as your internal organs start to fail. Here's your malignant smallpox. See, you still have the little punctate in the middle of the vesicle, but they're not pustules. They're slightly flattened, velvety, red, brownish. Okay. Yes, sir.
Are you gonna have pictures of these things on the test?
I do not use pictures. On any of the exams, I do not use pictures. So, yes, sir.
So, with the hemorrhagic, like internal bleeding is what kills them. So with the malignant smallpox, like is it the same deal? There's still internal
It
bleeding,
is.
so we're not seeing.
It is. It's multi-organ failure as well. A lot of this stuff you're just not going to be able to see. And your lab stuff just all start tanking. That's usually what happens with those. But usually you on the primary care side don't usually see that. Usually that becomes hospitalist, internist, or infectious disease doc specific for those. If you can get them early enough and you give them supportive care, a small percentage, I say very small percentage that have survived, end up with repercussions, okay, for the rest of their life because of this stuff. Alright, so what do you do for diagnosing? It's just clinical presentation, right? HPI and looking at it. That usually tells you it's smallpox, alright? If you want, here it tells you can obtain some samples. Alright, what you'll do is just take a Q-tip, you can de-roof one of the little vesicles, put it in there, try to get some skin on there so that you get a good sample, and then you'll put it in a vacutainer, and then you'll send that off. Alright? understand that this is considered highly contagious. Because it is highly contagious, your place where you're at lab-wise probably will not take care of this, right? So you're probably not gonna get an answer back anytime soon. They will probably have to send this off to the CDC. This is a reportable case, right? Because they will track it, and they'll see if there's any other cases that start popping up, okay? The public health awareness. Okay, so treatment, symptomatic care, right? Try to treat the symptoms. Because this is highly contagious, you need to isolate the individual. Okay? You need to isolate the individual because this is highly contagious. Now, you've got two choices there. You've got tecovirimat and brincidovir. They're both antivirals. Okay? The choice number one would be tecovirimat. That is specifically designed and approved by the FDA to treat smallpox if given early enough. And decreases the amount of time that you're hurt. Versus brincidovir, you can use in emergency cases only and not approved by the FDA for standard use. Okay? Now, do you give antibiotics for this? It's a smallpox virus. Do you give antibiotics for this?
No.
Yes, no, maybe?
Bacterial infection.
Well, you can read what it says there, right? But my point is, it's a virus. Antibiotics don't do anything for viruses, okay? So as it states there, secondary bacterial infections, from what? From those ruptured pustules, macules, vesicles, okay? Especially if they're kids, a lot of times kids start scratching them, rubbing them, doing a whole bunch of other things to them, and they may get a secondary infection. If you do see one, hey, give them some antibiotics and make sure it doesn't get worse, all right? The vaccine there tells you it may wane 10 to 15 years down the road, all right? And then if you have post-exposure folks, then you can give them the vaccine if it's been less than 4 days. Okay, if it's been more than 4 days, then it's a hit or miss, but your body hopefully can start taking care of that. There is an immunoglobulin for this. You do have to contact the CDC. Remember, any immunoglobulin, we've talked about AIG, right? The anthrax immunoglobulin. Any immunoglobulin will give you passive protection. Passive protection does not lead to lifelong protection. Passive protection will only stop stuff from getting worse at the moment that you give it. Okay? So there's a difference between using immunoglobulin versus using a vaccine. A vaccine will spur your antibodies for your body to be able to create specific IgG to fight whatever it is that it's developing. Versus an immunoglobulin, it just stops it from getting worse. It does not spur the body to develop antibodies to continue to fight it. All right, so there's a difference between both of those two. Okay? Here's your mortality rate, variable, minor, major, 30%, minor, 1%. Hemorrhagic, uniformly fatal. Okay? Malignant smallpox, frequently fatal. And you may have some significant scarring from some of the smallpox stuff. This is an infected smallpox site. And usually it's more common in kids than it is in adults because we kind of can control ourselves a little bit. You know, little kids usually can't. So with little kids, usually a secondary infection is more common. All right, so just keep that in mind. I like this chart. Just take a look at it. Right? It tells you the difference between smallpox and chickenpox, especially since both of them are clinically diagnosed. So when you go to look at them, you can see that it's chickenpox, not smallpox, right? The biggest ones there, your evolution of pox, one is synchronous versus one is asynchronous. What does that mean? That goes back to smallpox, they all look the same. Chickenpox, they don't look the same, they're in different stages, all right? That's a huge one, okay? Here are some pictures, right? So if you look at this side, right, you've got a little tiny one that's about to grow here, you got a medium-sized one here, you got a big one here, right? You got another big one here, but then you got a bunch of little tiny ones over here, right? So they're all different stages versus if you look at these are all pretty much big already, all right? So they all seem like they're in the same stage of development, all right? So a good way to tell the difference. The other big way to tell the difference, if you look at this chart, you can see smallpox, arms, face, legs, minimal trunk. Chickenpox, a lot of trunk, somewhat face, and a little bit on the arms and legs. All right. Here's some differential diagnosis for smallpox. All right. You guys get a little bit smarter. Let me ask you some quick questions. So Mpox, no longer monkeypox. Okay, this was first recognized around 1970 in the Democratic Republic of Congo, which is over in Africa. Initially, they thought it was solely from monkeys, but now they know it is from small animals and monkeys. In 2003, we actually had a small outbreak here in the US where they sent over some infected exotic animals that got mixed in with some, I'll say they were prairie dogs or something like that they had in a pet shop, and like 30 people got infected, but nobody died. Nice thing about monkeypox, not that bad. You'll eventually get over it. Okay? Just think of this as a milder version of smallpox. All right. Transmission, basically the same, close contacts with infected animals, rodents and monkeys, that they've realized now. The human transition. Okay. So the virility or the contagiousness of monkeypox is way, way less than smallpox. So where it takes a little bit with smallpox to get you sick, with monkeypox, it takes a much longer and a much higher dose to make you, or to get you infected. Okay, so that's another plus with the monkeypox. Okay, it does seem like the vaccine for smallpox does give you a little bit of protection for monkeypox as well. Okay, and there it tells you Central and Western Africa, right? So if I give you a scenario, I'll probably put you in one of those places. Okay, not as severe, the infectivity is not as severe as smallpox, still contagious. Incubation period, 5 to 21 days, so it's got a pretty long incubation period. And a lot of that has to do with the amount of viron that they inhale, the immunity, their nutritional status, their immune system. So a lot of that comes into play here for depending on how long it takes them to develop it. And there it tells you symptoms the same as smallpox, but less severe. All right. Here's a little kid with smallpox or Mpox. Okay. Here's a whole bunch of outbreaks. This slide's not going to be on the test, but here's a whole bunch of outbreaks. And when we tell you, look at the most commons. Okay. DRC, Democratic Republic of Congo, 5,288 cases, right? You look at Central Africa, 35 cases. England, these were accidental cases that came from Nigeria. Israel, imported from Nigeria. Democratic Republic, in 2020, 2,500 cases. Okay. Central Africa region or Republic, 6 cases, all right? So if you look at the majority of cases, they come from the Democratic Republic of Congo. So this one, same deal as smallpox, nothing extremely different. So The biggest differences that you're gonna see here are your Jacamavir. We added the Cidofovir here, but again, this one will be number 1, this one will be number 2, and then this one will be number 3 if needed. These two, this one and this one, are usually used for emergency purposes. Jacamavir is usually first line. Okay, same deal. Antibiotics for secondary infections, vaccines. Okay, nothing different than smallpox. All right. Guys have any questions? Yes, no, maybe. All right. Let's go ahead and take a break. Okay. I want to let you know I am available for you guys whenever you guys need me. Okay. Here's my office number. There's the room number. There's my cell number. Okay. If you guys have questions, please let me know. If you do text me, please let me know who you are, because I don't have to block you. All right? Especially if you're starting to ask me about STD questions. Like, oh, I'm not too sure if you're talking to the right person. Okay? But I'd like you to be aware that I am here for you whenever you guys need me. Most of the time, I am here. You guys can just walk right into my office and let me know what kind of questions you guys have. All right? Now, the other things that I've done, right, if you scroll down a little, you're set up into 3 different blocks here, right? These are the 3 different exams that you guys are gonna have. But if you look over here to the left, this right here, you guys can see this, right? Right? It says NCCPA adult laboratory values. You guys can download this, and you guys can start studying it now. Okay, and this is a tip from me to you, as a prior student, where you go to take the NCCPA exam, the PANTS. On the PANTS, sometimes they give you laboratory values. If you don't know what those ranges are, whether they're good or bad, they have a little reference button in the top right-hand corner that says lab values. You click on it, this is what you're gonna get. Okay, so if you study these lab values, you'll be slightly ahead of the game when it comes to the PANTS. You'll know where there are on the sheet, because when you start reading through the sheet, I think it's 2.5 pages worth, or 1.5 pages, where you have to scroll down, and remember, you only have 1 minute per question. All right, so this is just something for you to have. If you guys want, I just put that out there for you guys. All right. Then if you guys go to block 1, I got it broken out into 3 different sections, right? These are all your PowerPoint slides. This is a whole bunch of reference material for you guys. This stuff is not on the test. You can use this as reference to study for some of the tests, but this is for you to take home if you'd like, right? As you start practicing, you want something to refer back to, you can use some of this stuff. But then if you go all the way to the bottom, these are a whole bunch of check on learning questions for you, all right? I've tried to write a whole bunch of other questions to try to get you to think about some of the topics and subject material that we cover, all right? If you see anything that you need or want me to improve on for these, let me know. I'm open. Okay, don't stick stuff later on. Well, you should have done this. I'm like, well, you know what? If you told me, maybe we could have, right? So please, if you see something that we can adjust, let's make better for your peers that come after you, please let me know, all right? But this is what I have for you. Those check on learning questions are usually pretty good, since what I've been told. But if you need anything, I am available for you guys, all right? The other thing I do want to tell you, with the questions that I write, do not read into the question. Take the question at face value. If you start adding things to the questions that I give you, you're not gonna get them right, okay? So my questions are pretty straightforward, all right? Okay, so next we're gonna talk about STDs. or STIs? How many of you guys are comfortable talking about sex? Nobody? One person? 3 people? Man, okay. And the reason why I asked that question, right? These are some of the topics we're gonna cover, okay? It's a whole bunch of them. The reason why I asked this question, right, is, number one, you're already not comfortable talking about sex, right? Number two, do you think you're gonna have somebody younger than you or older than you in the room with you as a patient? We'll have both, right? Okay, so we'll take one step back from that one, and we'll go with, you have an older patient in the room with you, right? And I put it this way, do you talk to your grandparents about sex? Would you be comfortable talking to your grandparents about sex? Yes, no, maybe? No, yes? Maybe, okay, that's good, right? Depends on how close you are, no pun intended, right? But the reason why I say this is, number one, STDs in the older population, thank you Viagra, is going up. Two, the older population, to include some of the younger population, aren't gonna say anything until something bad really is happening at that point. Like it's about to fall off. Then they'll come in and they'll tell you, hey, it's falling off. It's like, man, you should have told me that like a month ago, right? Maybe we could have done something, right? But it's up to you as a provider to give them that opportunity to ask those questions, right? It's up to you to put in that availability for you to say, hey, I ask this of all my patients. Are you having any issues with intercourse? Have you had any serious history of STI or STDs? And a lot of times you can't say STD or STI, you wanna make sure that you tell them what it is. Have you had any sexually transmitted diseases or infections that we should be made aware of, right? Some of these infections, if you don't take care of them, can lead to other medical problems. Pelvic inflammatory disease being one of them. Pelvic inflammatory disease can make you infertile as a female, okay? If you don't treat them appropriately or soon enough. Okay? So sometimes you have to give your patients that opportunity to do so. So don't be too shy or coy about asking patients those questions. And here I'll put up some verbiage that you guys can use for some of your patients if you're not comfortable. Okay. Just remember, STIs can be spread via blood, semen, vaginal fluids, okay, or any other bodily fluids. All right. Now, my disclaimer to this, which is what's on this slide. If you want to go study at Starbucks, public library, or wherever, you can open up this slide deck, okay? Be very careful, but they don't call the cops on you, because there's some graphic stuff in there, all right? If you're gonna do it at home, just be careful that your kids aren't around if you have kids, so that they're not looking at some of this crazy stuff. That's my disclaimer for you guys on this slide deck. Anybody have any questions with that? Okay, the other piece of this is where, again, HPI is extremely important, right? What is your sexual preference? Females only, males, both? Female and female? Why do we ask those questions? But we ask them because we know there's a certain population that is more prone to certain STIs and STDs than others. Okay? But we won't know that unless we ask those questions, right? So don't be shy. Come out of your shell, right? So if you're not quite sure how to start the conversation, you can use some of these, okay? May I ask you a few questions about your sexual health and sexual practices? All right? At this point in the visit, I generally ask some questions regarding your sexual life. Is that okay? Okay? I always want to take their patient into consideration, right? There's some, right? Italian PA, first PA position I had, I got to know some of those FQ guys, right? When they come in, I'm not, may I ask you a few questions about your sexual health today? Be like, hey man, you've been wearing a raincoat? You've been using protection, right? It depends on the patient that you have and the comfort that you and the patient and relationship that you and the patient have as to how you approach them, all right? For those of you on the civilian side, National Guard, U.S. Reserves, that are gonna start practicing as soon as you get out, I advise you to use verbiage extremely cautiously. There are some patients out there that will take offense to a lot of things and will look at anything to try to say, I don't like you, I'm gonna go to somebody else, okay? So, very dependent on your patient. But these are some questions and some statements that you guys can use if you need to break the ice with your patients, all right? So don't be shy about asking your patients these things, because they can give you a lot of information, especially if they're there for an STD or an STI that day, right? So what kind of questions are you gonna ask? Throw it out there, raise your hand, we're gonna ask. We just talked about a couple of them. Are you sexually active? Yes. What else?
How many partners?
How many partners? Extremely important, right? Especially with females, especially within 1 month time period, right? Increases that possibility of carcinoma, cervical carcinoma. Okay, what else?
Birth control, yes or no?
Birth control, yes or no? Great point, right? Are you using it? Do you want to get pregnant? If you're not using birth control, specific topic or specific type, right? Condoms may prevent from pregnancy, depending upon which type of condom you're using. It may not prevent from STIs or STDs, okay? These are the things that are gonna be expected of you as a provider to kind of educate your patient. What else?
The history of an STI?
History of STIs, right? If you're a freaking flyer, probably should know that, right? If it's a female and it's a frequent flyer, then we could probably educate them and talk to them about, hey, these are some of the repercussions of having this multiple times. Okay, what else? Preference?
Male, female.
Okay, preference, male, female, correct. This will determine whether or not they're a higher risk category, right? Males who have sex with men, males who have sex with males, right, at a higher category risk for HIV. Right. What else?
Circumcised versus uncircumcised, hygiene.
Okay, you can do circumcised versus circumcised. Uncircumcised males are more prevalent for HPV, okay? What else?
Date of last menstruation.
Okay, date of last menstruation, more so for pregnancy, is what that would be. But right now, we're talking about STIs or STDs. Anything else?
Urination problems,
Say again?
painful urination, urinating.
Okay, those are standard symptoms, right? Pain when urinating, any leakage, any discharge, right? Good stuff to figure out whether they have gonorrhea or chlamydia, right? Good stuff. How about, and this is more so, no longer for the military, but more so for you reservists and National Guard folks that are gonna start practicing in the civilian sector. What's your gender identity? Do you see yourself as a male or a female? Those are big questions, right? Because that's gonna determine what their sexual lifestyle is, right? Right? So there's a whole bunch of questions that you can ask, okay, that'll get you to that point, okay? So this is one, is very specific for condoms, okay? The FDA makes the condom companies do random testing. On average, 2 broken condoms per 100 in the US, okay? Anal intercourse increases the slippage and the breakage, all right? So another reason why we should ask what that lifestyle is, right? Condoms can help, particularly latex, can help with pregnancy and STD and STI. Okay, latex. And then the other one on here would be ultimately, if it's 5 years past its manufacture date, you probably should get rid of it, okay? For those of you gentlemen who have condoms in your wallet since high school, probably time to get rid of them, okay? Not the right place to carry, okay? They do go bad. If you are allergic to latex, they do have options. Isopropylene, polyisopropylene would be one of them. This slide is one of those slides that you can try to remember for educational purposes for your patient, okay? There's 3 kinds of condoms, okay? There's latex, non-latex, and natural membrane. Natural membrane generally is lamb condoms, okay? Lambskin condoms, all right? That is lambskin cut. They used to use condoms a long, long time ago before condoms were the thing. They used to use sebum, intestinal linings from animals, okay? Hence, here's your lambskin. Things to remember, this is where science becomes a big deal. The pores of the lambskin are 1,500 nanometers in diameter, okay? When we look at science, we look at the diameter of HIV, which is 10 times the diameter. That 1,500 is 10 times the diameter of an HIV particle, and it's 25 times the diameter of HPV, hepatitis B. What does that mean? That means that natural skin condoms do not protect you from HIV and HPV, because the pores of the condom are way bigger than the virus particles. Things that you can do to educate your patients, okay? If they are just trying to not get pregnant, good, this will work. If you're trying to also protect from HIV or HPV, not gonna help you, okay? All right, stat slide, there's a whole bunch of it. Herpes simplex, 2018, 572,000 new genital herpes infections in the US, ages 14 to 49. That's the standard ages that you're gonna see, okay? Especially in the military. So you're gonna get some of this eventually in your office to discuss what's going on, right? World Health Organization numbers are even larger in 2016 for a similar age group, right? So 2 types, HSV1, HSV2. Most folks usually know HSV1 is in the mouth, HSV2 is in the genital area. Nowadays, with the way things are, a lot of lifestyles, a lot of time they overlap, they cross over. So sometimes you may have HSV2 in the mouth, HSV1 in the genital area. It's what it is, okay? So there it's telling you HSV2 in the genital area is not generally absolute any longer, all right? Reasons why this is extremely important to figure out if you have it or not. Pregnancy, okay? If you're pregnant with HSV, it can cause you early delivery. It can cause fetal death. It can cause some congenital deformities. It can cause what we call neonatal herpes. Okay? And that is because if you have a natural birth, when the baby comes out, the baby's gonna get all the HSV if you're actively shedding. Now the baby has it. Baby can't overcome that, usually the baby dies. Okay? If you notice that in women, usually around 36 weeks, you'll start the month-out cyclovir or acyclovir. Okay? You wanna try to protect them from HSV breakout when the baby is being born. The other option you have is to discuss it with the patient and maybe do a C-section. Okay? Anything to keep the baby from coming into contact with the infected area. All right? The immunocompromised, as we mentioned before, those are on almost everything, right? Their immune system's not working right. Now I'm getting attacked with HSV. What's my body gonna do? Generally nothing, you start getting HSV all over, right? So you try to get them antivirals as soon as possible. Remember, those are two high-risk populations that have very serious and bad outcomes if they end up with HSV, all right? The viron travel, that is a virus particle, which is what a viron is, okay? Whatever site it gets into your body at, it's gonna move to the dorsal root ganglion, and that's where it's gonna live. Period. That's where it lives for the rest of its life, i.e. the rest of your life, because it never goes away. All right? When you get stressed, when your immune system drops, this stuff generally wants to come back out. All right? Because your immune system's not working as well. But again, that's generally where it lives for the rest of its life. Okay. Here's some more stat stuff for HSV1 versus HSV2. Serologically, evidence approaches that almost 85% of adults in the world have HSV1. Okay? A lot of this, because it's very simple, I can kiss the baby. If I give them too many virons, anywhere between 100 to 1,000 virons is all that it takes to spread HSV to someone else. So if you have a spouse, one has it, one doesn't, if they're shedding or active, and they share some spit, they may get it, okay? Can you share it and get it from a cup? Yes or no? Okay, so that answer is a maybe. That answer is a maybe, all right? So it depends on how much virons are left on the cup, depends on how hot the cup is, depends on the room temperature, and depends on the humidity in the room, okay? That's why it depends. The stuff doesn't usually last outside the body very long, okay? Usually a couple of hours, may last on some inanimate object that you may share with someone, but depends on how many virons you left on there as well. So that one depends. Okay? A lot of times, the way a lot of little kids usually get HSV1 is usually when parents have them when they're really little and they're kissing them and hugging them and holding them, but they're not realizing that they have a slight outbreak or they're shedding the virus, and they usually spread it to little babies. So that's why HSV1 percentage-wise in the population is very high. But if you look at HSV2 is a lot lower. Okay. Okay, so here's some signs and symptoms. Your initial outbreak is going to be the worst outbreak that you have, period. Okay, it's going to last the longest, and it's going to be the worst, and you're going to have the most symptoms out of all the ones that you ever get ever again after that one. Okay, that one should technically, keyword, technically be the worst one. Now, there is a small bit of population where they continuously get it. Their immune system can't handle it, and it just continues to pop up, and we have to give them suppressive therapy. Okay. But here, for the initial, you're going to get a whole bunch of different symptoms: fever, rough onset, anorexia. Listlessness means you're tired, fatigued, and you don't feel like doing anything. Okay. You may get some gingivitis. You'll get some regional lymphadenopathy. It says the acute disease lasts 5 to 7 days. A little longer than that. Okay. A little longer than that for your initial. Okay. It may heal in 2 to 4 weeks. So these things go away on their own, even if you don't do anything. They'll go away on their own. The problem with that is, number one, you have to think about that person's lifestyle. Is it interfering with their life? Right? Is it bothering them? Do they feel self-conscious? Okay. There's a lot of things that you should think about when you're like, hey, I need to give you some meds. The biggest thing that you need to think about is the viral shedding of the virus. Initially, this thing says 3 weeks or more for your initial. Usually afterwards, if you get other ones, usually the virus shedding usually lasts about 5 to 7 days. Okay, but for your initial, 3 weeks or more. That means that even after this thing has healed, right, depending on when that shedding is occurring, you can still spread it to somebody else. So the sooner you can get them on some antivirals, the better off you'll have. Your patient will be and the better the outcomes will be, right? Okay, so HSV-1, 2, you'll have a prodrome, burning, tingling. So if you've heard some folks say, oh, my lip feels like it's burning, or it's throbbing, right? Your body is telling you, hey, I'm about to pop out, right? So usually what we do is, when we educate our patients, we let them know, hey, as soon as you feel any burning, tingling, as if you're gonna break out, take your medication, okay? That decreases the amount of time that it usually breaks out for, if it doesn't stop it completely, if they caught it early enough, all right? And the deal is, it develops erythematous papules, rapidly develops into intraepidermal vesicles, they pustulate, they ulcerate, and they crust over, okay? There it says fewer than 2 recurrences manifest annually. That is really dependent on your patient's immune system, okay? That is really dependent on your patient's immune system. If their immune system can't handle it, it'll be a lot more than 2, okay? And that's where we talk about, hey, maybe we should do some suppressive therapy for you, okay? And there it tells you some people have it monthly, which means, hey, we should probably give them some suppressive therapy as well. So, herpes genitalis, okay, generally type 2, generally, okay. The symptoms are much worse with females, okay. They're much worse with females, okay. The labia, the clitoris, the perineum, the vagina, and in some cases, the cervix may be involved, okay. And remember, within that anatomy, right, once those vesicles rupture, they ulcerate, okay, this is what you're doing, okay, there's no protection from that. It hurts a lot for females, okay. So females, you try to treat as soon and as fast as you can, okay. That is extremely uncomfortable for them, all right. Now, can you get herpes anywhere else? Yes, if you read the slide, yes. The answer is yes, you can get herpes anywhere. Can you get it in the eye? Yes, you can get herpes in the eye. If you get it in the eye, you need to send them to the ophthalmologist, not the optometrist. Guys got that? And a lot of people send these people to the optometrist where they give glasses versus the ophthalmologist where they actually take care of your eye's health. Okay? So make sure they go to the ophthalmologist, not the optometrist, all right? Okay, here it tells you 90% of patients reactivate within 12 months. So usually within 12 months, you may end up having another outbreak. That's just standard, the way the disease process works. But again, the second outbreak usually isn't as bad as the first. And here it gives you some stats. HSV-2 infection, 38% had recurrences of six recurrences within 1 year. Okay, 20% had more than 10 recurrences in 1 year, right? Medicine is evidence-based. Stats, that's what this is. Just remember, it's based on your patient. Okay, based on your patient. All right, so subclinical basically means that previously dormant virus becomes active again, but the person does not experience any symptoms because it is coming back so slowly that it's truly not affecting the person as bad as it used to. Okay, that's your subclinical presentation. And then, of course, your symptomatic presentation is, hey, the thing's becoming active and it's causing me some problems. All right, so two different means of reactivation there, but more common for HSV2 than HSV1, subclinical stuff. Okay, and they label it important enough that prodrome needs to be looked at, because you get the prodrome both in your oral area or in your genital area. But understand, when you talk to your patient, as soon as you feel that, you start taking your meds. Okay? They are painful lesions. Okay? They are painful lesions, especially for the recurrence. Okay? The difference is that your symptoms are not as bad when they recur. Okay? We mentioned that before. Here it tells you instead of taking weeks to heal, right, 3 to 4, now it takes 8 to 10 days. Okay? Usually it'll heal within a week. All right? If you start your medication even sooner than that, it might not even last that long. All right? Here it tells you viral shedding lasts an average of 5 days. If you take the medication, that should also decrease your viral shedding as well. All right? And again, for HSV2, the symptoms are more severe in women. Recurrent lesions tend to be milder and cause fewer symptoms, right? Because your recurrence is usually not as bad as your initial. Right. So here's some stuff, physical wise, prominent lesions on the mucosal surface, right? So if you're gonna remember anything, whenever you hear clustered vesicles on a erythematous base, first thing you should think about is HSV, okay? There are certain words that are trigger words that should like make you think of that. These are the trigger words for this one, all right? So if you hear clustered vesicles on a erythematous base, generally your first thought process should be HSV, okay? There they develop a crust within 5 to 7 days, whether it's oral or genital, okay? It could be anywhere else, and you can self-inoculate yourself, all right? So this next picture I'm gonna show you, I will come back to the self-inoculation thing, and here it tells you you can self-inoculate or auto-inoculate your eye with this. Just make sure you send them to the ophthalmologist, not the optometrist, all right? But this is what we consider cluster vesicles on a erythematous base, right? So these are all your cluster vesicles, and you can see a faint red line against this erythematous base. It's just because they're all clustered, that's why you have that. Okay. So that's your key words here, but what's wrong with this picture besides the person having herpes? He's got fucking gloves on, man. This is like gross, right? All right. Now, the reason why I point that out, okay, and for those of you who are in my junior clinical group later on today, we'll talk about wearing gloves. Okay, you should wear gloves all the time when you're interacting with patients. Okay, 2 big reasons. I don't know what you have. I don't know what you got. I don't know where you've been. I don't know what you've been touching, okay? So, you as a patient, they got something, that's why they're here, right? So you don't want to touch them with your bare hands, okay? Use this case as an example. Why is this guy touching him with his bare hand, right? That's one. The other one is for your protection as a provider, okay? You guys are PAs. When you go in to do a physical exam, you want to protect the patient and you want to protect yourself, right? By protecting yourself, you're wearing gloves so that you don't get anything and you don't take it home to your family, to your kids, to your pets, to whatever you got at home, okay? So, one, you don't want to give anything to your patient, so I don't know where your little grimy paw's been, And two, I don't want whatever that patient has to come on to me, for me to take home, okay? So wear gloves, all right? Wear gloves. I want you guys to do that here because that's gonna develop muscle memory for you when you get to phase 2 and then you start practicing. You're gonna get used to just putting on the gloves before you start touching folks, all right? You guys get used to not having to wear gloves because you guys are around a whole bunch of healthy folks, hopefully, right? But we don't want you to get or have that scar of not wearing gloves, all right? So if at all possible, try to wear your gloves so that you can kind of develop some of that muscle memory as you continue on in the profession, all right? These are some ruptured vesicles, so it looks a little bit shiny, but you still have a bunch of cluster stuff right here, and the little redness would be that erythematous base that we're talking about, okay? Here's some more vesicles, okay? Here, here, here. Okay. You can see the vesicles here. You can see the vesicles on the tongue. You can see the vesicles on the labia, all right? Reason why you wear gloves, okay? I've seen students do a mouth exam by, say, ah, and flashing the light and just moving the light around inside the mouth. How do you see into the back of the mouth or under the tongue if you're just flashing the light in the mouth? Okay? Put on some gloves. Hook that dude. Hook him. Look inside the back of his mouth. Okay? You want to hook him with your finger? Use a popsicle stick. Okay? Time to lift this tongue up. Right? I'm sure when you guys did your clinicals, physical exams, they're like, hey, grab a 4x4, grab the tongue and lift it up and look it around. You guys do that? Yes? No?
Yeah.
Yeah, no? Okay. So technically, when you're looking at the tongue, you should like grab it. Usually you use a 4x4 so that it doesn't slip out of your fingers, and you can pull it up, pull it to the sides, so that you can see all the way around it, right? There's 4 sides to the tongue, right? This way you can get a full view of what's going on all the way in the back of the mouth, right? Because of some of these things. Any mucosal surface can get this. Any mucosal surface can get this, all right? So just remember that, okay? Here's the ones right on the outside of the tongue, outside of the lip, right? These are ruptured already. This one right here is ruptured, right? So this one's ulcerated. Right? And this is generally what we would call a cold sore, right? So generally speaking, that'd be an HSV1, right? Versus an HSV2. But nowadays we don't know what that may be, right? Due to people's lifestyle. Now, diagnostic wise, just like smallpox, just like monkeypox, right? We're just gonna take a look at it and we're gonna clinically diagnose this. Do I need to send this stuff off to the lab? I do not. Can I? I can. Now, you can do a viral culture, or right there you see it says Zank smear. Okay? So if you see multinucleated giant cells for lab results, think of HSV. Okay? Giant multinucleated cell, HSV. We don't generally do Zank smears anymore, but in a lot of exam questions, they still use that as a laboratory test for HSV. And in some places, right, overseas specifically where they don't have PCR, this is what they use, okay? All you do is cut the top off of one of those little vesicles, take a swab, jam it in there, swirl it around, and then look at it under the microscope. That's all you're doing, and staining with gemcitabine, okay? So when you look at it, it looks like this. Okay. So this is one giant cell, right? And then you have a bunch of little nuclear cells in there. Okay. So that's what we call a multinuclear giant cell on Zank smear. All right. Okay, treatment, real simple, right? Regardless of whether it's initial, recurrent, or suppressive, you've got your 3 choices there: acyclovir, valcyclovir, famciclovir. All right. Now, Acyclovir, longest one, most tested, very first antiviral, right? I think that came out like in the 70s or something to that effect, right? Nowadays, we use valcyclovir. That is the probably best choice that you'll have. Okay? And part of that is understanding pharmacodynamics, right? Valcyclovir, once it passes through gets processed through the liver the first time, actually converts over to acyclovir. Like, holy smoke, then why can't I just give them acyclovir? Because it's being transformed in the liver, in the body already. Its accessibility is about, bioaccessibility is about 55% compared to acyclovir, which is about 5 to 10%. So you get more medicine from valcyclovir. Valcyclovir, I can do 1 to 2 pills per day. Acyclovir, 3 to 5. Okay? So sometimes you have to look at the efficacy of the medications. All right? Now, why is this still on there this way? More so for those of you who are going to practice in the civilian sector. The price difference between acyclovir and valcyclovir is pretty big. Okay? Especially for someone who has no money or has no insurance. Okay? That's where we go to that socioeconomic aspect of the people you're taking care of. Okay? One of the reasons why PAs were made, not just for wartime, but we were made to cover down in rural areas of the United States. Some of these rural areas don't have one. Okay? So you need to look at what else would be effective enough for you to be able to treat that they can afford. Okay? And acyclovir would be one of those things that they can be treated with and that they can probably afford. Okay? It'll just be an inconvenience of them having to take it 3 to 5 times a day versus just taking it once or twice a day with valcyclovir. All right? So those are your treatment options. For suppression, I would recommend valcyclovir as well. Okay? Big deal. Reason why we put this on here is because it's a CDC recommendation. Valcyclovir has been shown to be most effective antiviral medication in decreasing the rate of HSV2 transmission in discordant heterosexual couples. What does discordant heterosexual couples mean? That means male-female, number 1. Number 2, one of them has something. In this case, one of them has HSV, the other one does not. Okay? Valcyclovir has been one of the best ones to show that they don't spread it to each other. Okay? Particularly for HSV2. Okay, usually 6 or more outbreaks is what we look at before we start saying, hey, let's go ahead and put you on some suppressive therapy as well. I put these topicals on here, Denavir, Abreva. You can probably buy those over at CVS or Walmart. And I added them because you're probably going to have patients that are going to come in and ask you, hey, can I just go down to Walmart and just get that and use it? Okay. So the answer is yes, you can. Okay. Question is, how effective is it? Okay. So the topicals aren't necessarily extremely effective. All right. And then if you look at the topical instructions, topicals are like apply 3 to 5 times a day or something to that effect. Right? But let's understand the disease process. It is systemic. Do you think something topical is going to help something systemic? Okay, that's where a little bit of understanding of some of the science helps, right? So oral medication is generally the best, okay? You can tell them you can try it, especially for HSV1. None of the topical stuff works for HSV2, okay? For one, it may give them a placebo effect and they may think it works better, all right? It may decrease it by a day, maybe, if it's working for them. But let's understand pathophysiologically, this is a systemic issue. Oral usually works a lot better than topical, all right? Okay, so some complications, right? You may get some bad bacterial infections, especially if you start scratching, or once the blisters break and they ulcerate, you know, depending on the locations that they're at, right? Cause now we're talking vaginal canal, we're talking shaft of the penis, head of the penis, inside warm, dark, moist places. It can spur on bacterial infections, okay? So things to keep in mind. HSV can spread to your meninges or cause encephalitis if it becomes systemic and works its way to the central nervous system. Right? Things to keep in mind. That can be a complication. Here it's talking about babies born to mothers with genital HSV. Okay? That's where we talked about that neonatal herpes. Neonatal herpes is basically 100% fatal. All right? Ocular infections, we mentioned, hey, you can self-inoculate, especially if you're not washing your hands after you touch your vesicles, yes, right? Or wearing gloves when you're doing a physical exam. Okay. Anybody know what eczema herpaticum is? Yes, no, maybe? Okay, you guys generally get that when you don't wear gloves. Okay. What is that? That is herpes on your fingers. Herpes on your fingers is generally what you know. So the largest number that they found in certain studies have been providers for eczema herpaticum, just because a lot of folks don't wear gloves. Okay. Oh, I'm sorry. It's herpatic Whitlow. My mistake. Herpatic Whitlow. Herpatic Whitlow is the herpes on the finger, and what generally providers get. Okay, my mistake. And then you end up with herpes gladiatorum. Usually, when you're doing combatives or when you're wrestling, you'll do that skin-to-skin contact. You can spread it that way as well. That's what herpatic Whitlow looks like. Okay, on your finger. This is what we discussed before. If a pregnant woman has HSV, you need to be aware of that. Okay, so as they get closer to delivery, you want to make sure that that is well contained. On average, if someone has it, on average, about week 36, we'll start them on either a cyclovir or valcyclovir to try to make sure that by the time the baby is born, if you're gonna deliver vaginally or naturally, you don't infect the baby. Other options are discussion with a parent, right? It's a C-section. This is the one where the newborn comes out, everybody wants to hold him and touch him. Depending upon what the individual person has, is a way to spread it to the infant, to the baby, okay? Here it says a cyclovir is recommended for suppressive therapy for mothers if not already on suppressive therapy starting at 36 weeks to reduce transmission, all right? I would also add valcyclovir on there, okay? Acyclovir. Valcyclovir nowadays is probably the primary antiviral that they use for this, okay? So you can add that there. And just remember, none of this stuff is 100%. Okay? Your baby still may end up with some HSV. Here are some differentials for herpes simplex virus. And then this is the beginning of HPV. And if you want to stop here, we can. If not, we can go on for another couple minutes and then stop. Sure, stop. Sounds good. All right, so we'll stop at HPV.